This is an introduction to pharmacology. First, we're going to talk about medication classification. This is called nomenclature. So the chemical name is always something that you can't pronounce, and you have the generic name, which is a non-proprietary name, so it's not a trade name. An example here would be ibuprofen. It's given by the U.S. and it's same active ingredients. It's given after the patent expires. A trade name is a proprietary name. That would be like Advil or Motrin, which are registered trademarks. You have uncontrolled substances and controlled substances. Now, uncontrolled substances do not pose any risk of abuse or addiction. An example of this would be like antibiotics. Controlled substances have potential for abuse and dependence. So they're scheduled between Schedule 1 and Schedule 4. The schedule of drugs is required by the Controlled Substance Act. And so a Schedule 1 would be that there's no currently accepted medical use and there's a high potential for abuse. That would be like cocaine. Actually, marijuana is currently a Schedule 1 still. A Schedule 2 would be like there is a medical use, but there's a high potential for abuse. That would be like hydrocodone. Class 3 is a moderate to low potential for physical or psychological dependence. And a Class 4 has a low potential for abuse and low risk of dependence. So, and actually there is a Class 5, lower potential for abuse than the 4 drugs, will contain limited quantities of narcotics in them. So, pharmacological principles, this is an overview. Pharmacodynamics. This is what the drug does to the body. Pharmacokinetics. This is what the body does to the drug. For example, absorption, which is the transport of the medication from where it's administered to your blood. So getting it, if you ingest it, getting it to your blood. Distribution is transporting the medication from your blood to the site of action where it's going to have something happen. And then metabolism is the breakdown of the medications. Usually it's via the liver. And then excretion, elimination of the medication. And this is usually via the kidneys. Pharmacotherapeutics, this is the clinical use of drugs. Drug regulation is done by the Food and Drug Administration, which regulates the approval and use of all drugs, and then the DEA, which is the Drug Enforcement Administration. Toxicology, this is the study of adverse effects of drugs. Pharmacologic principles, so dosage forms, you have enteral, which means it's absorbed via the GI tract. So you can have PO, sublingual, buccal, rectal. Liquids are absorbed more readily and more quickly than solids. So if it's a liquid form, you start to see those liquid gel caps, they act faster. That's because they're in a liquid, but yet you can swallow it so it doesn't have any nasty taste to it. Enteric coated means it's not absorbed until it reaches an alkaline state of the intestines. It's designed to protect the stomach lining so that it doesn't get irritated. Because it is enteric coated, it can't be crushed because you can't damage that outer coating. So any kind of enteric coated medication can't be crushed, can't be divided in half or anything like that. Extended release. These are layered release forms. They can't be crushed either. So they're layered to dissolve at time periods. And so if you crushed it, an extended release medication, you're giving all of those doses all at once instead of giving over time. An oral dissolving tablet, they're absorbed via the mucous membranes, so it's readily dissolved right into the bloodstream. So topical works directly on the skin, or it passes through the skin to get to circulation. The absorption of topical medications is very erratic, very unreliable. We don't really recommend it, especially in kids, to get topical medications because their skin is very absorbed. It absorbs really readily. Topical examples are skin, eyes, ears, nose, lungs, rectum, or vagina. So those would be, of course, suppositories for those last ones. Parenteral, so bypassing the GI, these would be injections. So you have IV, IM, sub-Q, intradermal, intra-arterial, intrathecal, and intra-articular, which is into the joints. So absorption. Bioavailability is the extent of absorption, which is how much is available to elicit a response. First pass effect means that the liver takes it up before it reaches the blood, which reduces the bioavailability. Most medications absorbed via the GI tract have a first pass effect. So if it's PO medication, it's more than likely going to have a first pass effect. So it's going to go to the liver before it gets to the blood, and that's going to greatly decrease the medication's bioavailability. Factors that affect absorption, well, the route. Of course, IV is going to be the fastest, GI will be the slowest, and GI-PO will be the slowest. Acid changes in the stomach will change the absorption of the medication. So some medications like an acidic environment and some like an alkaline environment. Absorption from the intestines. If there's any kind of decreased blood flow to the intestines, any kind of inflammation going on in the intestines, if there's been any scarring in the intestines from surgeries, that's going to decrease the absorption. So that's going to affect it. The presence of food. The presence of food changes the pH of your stomach. So that's going to change the absorption rate of certain medications. Age. Children have immature kidneys and livers. So they're going to metabolize it slower. Their kidneys are going to excrete it more readily because actually their immature kidneys, they won't dilute the medication. Older folks, elderly, they have decreased function of kidney and liver. So they're more likely to hang on to medications because we're going to talk about this in a minute, but the liver metabolizes the medication and then the kidneys excrete the medication. So if you don't have very good function of your liver, it's not going to be metabolized as effectively or as quickly as it would before. So that means the medication is going to stay in the system longer. And then if the kidneys aren't working very well, the medication is not going to be excreted as quickly as it would have before. Enteric coating, we talked about this. The alkaline state is when it's waiting for an alkaline state to start dissolving. Antacids, if you give them with antacids, it may cause them to release early because if you give antacids, it decreases the acid in the stomach, which will increase the pH, which will create an alkaline environment. So enteric-coated medications will actually start dissolving in the stomach instead of waiting to get to the small intestine. Chronic illnesses and surgeries, chronic inflammation, healing from surgeries, you're going to have scarring. Any scarring that there is or any inflammation, that's going to decrease the absorption. So distribution, so this is the transport of the drug via circulation to the site of action. So it's going to distribute fastest to areas with extensive blood supply. So like the heart, the liver, the kidneys, and the brain. Okay? Once the drug enters circulation, it begins to be eliminated. It is metabolized by the liver and excreted by the kidneys. Albumin carries most protein-bound drugs. A bound drug is an inactive drug. If you have incidences of low albumin, in the body, there's a potential for toxicity because you have lots of unbound drug so that allows free drug to be out in the bloodstream to create a response. Two protein-bound drugs will then compete for binding sites. So one's going to bind, the other one's not going to bind, so you have a potential for toxicity in one of those drugs. Metabolism, you have biochemical alteration of a drug into either an inactive metabolite, a more soluble compound via the liver, so it can be excreted via the kidneys, a more potent active metabolite, which we call a prodrug, which means it must be metabolized to be in an active form, and then it can be metabolized or altered into a less active metabolite. Most drugs are metabolized by the liver. Cytochrome P450 enzyme, it helps to metabolize many drugs. We've noticed that genetics causes either an increase or maybe a decrease in these enzymes, the P450 enzymes. So people that are missing these enzymes or have limited amount of these enzymes may have trouble metabolizing certain drugs, which would make it hard to eliminate them from their system. Enzyme inhibitors, these inhibit drug metabolism. This would increase the amount of drug in the blood. You have enzyme inducers, which stimulate drug metabolism, and these decrease the amount of drug in the blood. So liver function plays a role in how fast or slow drugs are metabolized, which means how long the drug stays in the body. So liver function is super important. And then excretion. So now we'll talk about kidneys, my favorite thing. So the liver makes the meds more water soluble, which makes it easier for the kidneys to excrete. So renal excretion is the most common way medications are excreted. They go through the renal tubules. At the renal tubules, it's decided whether the medication goes back into circulation or out into urine. Biliary excretion, some are excreted via biliary excretion, which means it's excreted into the bile, which then goes into the stool. So renal function plays a big role in how well the drug is excreted. Renal dysfunction will slow the elimination of the drug. Thus, you'll have the drug staying around in the blood longer to do more action. So increases your risk of toxicity. Some terms. So pharmacokinetics is what the body does to the drug. Okay. So half-life. This is the time required for half the drug to be eliminated. It takes about 5 half-lives to get out of the system. So say you have a half-life of 2 hours, okay? So in 2 hours, 50% of the drug is out of the system. In another 2 hours, 25% of the drug is out of the system. More, okay? So you dropped it to 50% in the first 2 hours. In the next 2 hours, you drop it to 25%. 2 hours from that, you drop it to 12.5%. Okay? Another 2 hours from that, you drop it to 6.25%. Another 2 hours after that, you drop it to 3.125%. See what I mean? So that's why it takes about 5 half-lives to get something completely out of your system. That's why it's important to know what the half-life is. Generally, drugs are given at their half-life. So if a drug had a half-life of 2 hours, then it would be given every 2 hours to keep a steady state in their bloodstream. So what's a steady state? It's a consistent concentration of drug in the blood. It takes about 4 to 5 half-lives to create a steady state. So that means every 2 hours we're giving the medication. So every 2 hours for 5 times until there's a nice steady state of drug in the blood, okay, to create a nice therapeutic response. So onset of action is the time to elicit a therapeutic response. So it's when you start to have a noticeable response, when you're starting to feel better, starting to have a reaction to the medication, okay, an action to the medication. So the peak time is the time to reach the maximum therapeutic response. So this is, peak effect is the maximum effect, which is different than onset of action. Onset of action means it's starting to work. Peak action means that this is the max effect. This is when it's going to be working the absolute best, okay? Duration of action is the amount of time that the drug elicits therapeutic response. So when I start to feel better till I'm all good, and then I start to feel like the drug is wearing off, okay? That's the duration of action. Therapeutic drug monitoring, we may do peak drug levels. The peak level is drawn, it's a blood level that's drawn at the peak effect time, okay? So it's at our peak time. So it's drawn when the drug concentration is highest in the blood, okay? So you have to look up when the peak time is for that particular medication, and then you know when to draw the blood to find out the drug concentration. And then you want to know trough levels. These are drawn right before the next dose. It tells you what the lowest amount of drug that's in this blood at any given point, okay? Because if we're right about to give another dose, then we know this is the lowest point. And these peaks and troughs are super important, and we're going to talk about that in a little bit. So pharmacodynamics, what the drug does to the body. A therapeutic effect is the intended effect. This is the positive change, the things we wanted to happen. The mechanism of action is how it works. It can be a drug receptor interaction, which means when it binds to a specific site to either block or stimulate a response. It can be enzyme interactions, which means it either inhibits or stimulates an enzyme. It can be non-selective interaction, which means it just targets a cell, like chemotherapy. Chemotherapy targets rapidly dividing cells. It's not a specific cell, it's just one that's rapidly dividing. That's why it kills it. That's why you have the side effects of chemo with the skin issues and the mucous membrane issues and the hair falling out issues, because it's not specific. It targets a rapidly dividing cell, and that's it. It doesn't matter what it is. Okay? An agonist, these are super important that you understand. Agonist binds to or mimics a receptor activity, so it stimulates an action. Okay? An antagonist blocks the usual receptor activity, so it blocks an action. Okay? Agonist stimulates the action, antagonist blocks the action. Okay, so a partial agonist has limited activity to the receptor sites. A lot of times you'll have the receptor activity, but you won't have the bad side effects. So it essentially kind of does both. It's an agonist, antagonist kind of action. So the use of drugs to prevent and treat diseases. This is pharmacotherapeutics. Contraindications means it makes the medication dangerous to the patient, so we wouldn't want to give it. Acute therapy means this is treatment for the illness, okay? And then maintenance therapy is preventative treatment, like oral antibiotic medications before having dental work done or something, okay? Supplemental therapy, that's replacement therapy. That's replacing something that we need. We're going to talk about diabetes in a little bit. And so when you give insulin, when you have type 1 diabetes, you're not making insulin. So you give insulin. That is a supplemental therapy. It's a replacement for something that your body's not making. Palliative therapy, this is comfort. So quality of life, pain medications, things like that. Supportive care, this helps to maintain body functions. This would be like IV fluids, TPN, things like that. Adjuvant therapy, this is in addition to the primary treatment. This is designed to help the treatment work better. It's to maximize the effectiveness of the primary treatment, okay? Prophylactic therapy, this is prevention. Antibiotics before surgery or antiemetic prior to chemotherapy, okay? Empiric therapy, this is treating the most likely cause. This would be like prescribing antibiotics that will most likely be effective before the culture and sensitivity results come back. So say they have an ear infection, we're pretty sure Augmentin will help it, so we're going to prescribe this. If it doesn't help, then we'll try something else. Or if they have a urinary tract infection, most of the time this is what causes it, we'll give this antibiotic. We'll send off the urine for a culture and sensitivity test. When it comes back, we have to look at it and make sure that the antibiotic that we prescribed is actually effective for the bacteria that it grew out. Okay, so I don't want you to be confused with maintenance therapy. Maintenance therapy prevents an illness from happening. Okay, maintenance therapy would be like if they have say they have asthma, and so there's asthma is usually caused by an allergy, okay? So they're on allergy medications so they don't have an asthma attack. This would be something that they take every day. So it's maintenance. It's to keep them from getting sick, okay? So hopefully that's not confusing. Pharmacotherapeutics, adverse effects. So allergic reactions. This means there's an immune response. The immune system goes into action. It thinks that there's a problem, there's something foreign. Anaphylactic reaction. This is a life-threatening allergic reaction. Okay. Extrapyramidal symptoms. This is abnormal body movements. Immunosuppression. This means it suppresses the immune response. Common immunosuppressant is corticosteroids. They suppress the immune response. Idiosyncratic reactions. These are unexpected responses. There tends to be a genetic tendency. This would be like, okay, expect Benadryl to make a kid really sleepy and it ends up making them hyper. That would be an idiosyncratic reaction, just something we totally don't expect. Teratogenic effects. These mean it causes structural defects in the fetus. The fetus is most vulnerable 3 weeks to 3 months. So in that first trimester is when they're most vulnerable to teratogenic effects. Carcinogenic effects, that means it can cause cancer. Toxic effects, these are adverse effects that is severe, can be life-threatening, usually is from too high a dose of medication. Nephrotoxicity, this is damage to the kidney. Hepatotoxicity, this is damage to the liver. Monitoring, what are we going to monitor? We're going to monitor for adverse effects, which are undesired effects. We're going to monitor for therapeutic effects, which is our intended effects. We're going to monitor the therapeutic index. This is the ratio of a toxic level versus a therapeutic level, okay? So there are some drugs that have a narrow therapeutic index, which means that there is a very small window between when it's therapeutic and it's where you want in the blood, and then where it can go toxic. So for those drugs that have a narrow therapeutic index, they will need to draw peaks and troughs, because we really need to know what is the maximum amount of drug that's in that blood at any given point, and what's the lowest amount of drug that's in the blood at any given point. So we need to know peaks and troughs if it has a narrow therapeutic index. There are several drugs that we're going to talk about that will have these, so you need to know those drugs that require that. Drug concentration, this is the amount of drug that's in the blood. And then we're going to monitor the patient condition, their current disease, and any other medical conditions, especially their liver and their renal function and circulation issues, because all of those greatly affect the distribution with circulation issues, and then the metabolism with liver, and then excretion with renal function. So pharmacotherapeutics, tolerance means a decreasing response to a repeated drug dose. So it means they're getting the same drug amount, but it's not working as well. Like say it's a pain medication and they had a pain of 10 out of 10. They gave the medication and it would drop the pain down to a 5. Okay, 5 out of 10. So it's pretty effective. But now they're given the same amount of drug, but now the pain's only dropping to like a 7. Okay, so that is tolerance. So it means you need more and more drug in order to get the response that you had before. That's very different than dependence. Dependence is a psychological or a physiological need for the drug. With dependence, you will have withdrawal symptoms. Okay. Drug interactions, this can be with over-the-counter meds, can be with herbal stuff, can be with food, other drugs. It can be additive, which means 1 + 1 = 2. It can be synergistic, so 2 drugs together can work even better than the 2 would be separate. Okay? It can be antagonistic, which means the 2 drugs together, they fight each other, so they don't work as well as just one of them would have been. Okay? Incompatibility is a chemical deterioration or a precipitant. If ever you see any cloudy or visible flecks in anything, you need to discard it. That means it was incompatible. It was actually creating some precipitant kind of chemical reaction with those 2 drugs together. So there are certain things that are required on a prescription order form. The patient's name, the date the order was written, the drug name, the drug dose amount, dose frequency, the route of administration, and the prescriber's signature. All of these must be present on all the orders, okay? You cannot give the drug if any part of these details is missing, okay? You cannot assume anything. Even if you know that the only route that this medication is administered is PO, it doesn't matter. You have to have them rewrite it to include the route of administration. You have the prescribing information, then you have the 9 rights of medication administration. First right is the right drug. Lots of drugs look alike and sound alike, so make sure you have the right one. The right dose, no trailing zeros, and use a 0 before the decimal. If you have a trailing 0, it'll look like 10 times more, and if you use a 0 before the decimal, they'll notice that there is a decimal, okay? The right time, when was their last dose, okay? You need to make sure that it's a correct time. The right route and the right form. Enteral syringes should be amber syringes. Parenteral syringes should be clear, okay? The right patient. You need 2 identifiers, name, date of birth, right? The right documentation. Don't document the medication was given until it was done, okay? The right reason. Why are they getting the medication? Does it make sense that this patient is getting this medication? And then right of the patient to refuse. But you must explain the potential harm to the patient. You can't just say, okay, you don't have to have it, and don't let them know. They need to know the consequences of them not taking the medication. You also have to tell the doctor or the prescriber that the patient refused the medication, because he may change his orders depending on that. So lifespan considerations with pregnancy. Trimesters, the first trimester trimester, they have an increased risk of teratogenic effects, which is those structural defects. And the third trimester, they have an increased amount of drug that gets to the fetus, so they're more likely to have adverse effects from the drug. Maternal factors, how their kidneys and their liver is functioning, how the genetics, those enzymes. There are pregnancy safety categories over on the right side, the A, B, C, D, and X. These have to do, it's fairly safe to give A and B drugs. It's not very good to do C and D, but the physician may decide that the risks are better than the benefits are better than the risks, so they may have to go ahead and still give a medication. So breastfeeding, some meds pass through the breast milk. So if a medication is being given temporarily, they could do a pump and dump kind of thing where they just pump the breast milk and dump it out and not give it to the child, so that the child doesn't suffer any deleterious effects of the medication. For 65 years and older, there's a decline in organ function. So that means that the medications are going to stay in the system longer. So liver, the kidneys, the heart, they're all declining in their organ function. They're going to have polypharmacy, which means they have multiple providers, multiple prescriptions, multiple pharmacies, okay, lots of meds. Declining vision and manual dexterity, so they're going to have a high risk of making mistakes, okay. They're going to do pill splitting and non-compliance because they have a fixed income. It's a cheaper option. Let's just split the pill instead of take a whole one, because then the prescription goes longer, right? Patient education and concerns. They may have lack of understanding, hearing difficulties. So even though you're trying to educate them, they're not understanding what you're saying because they can't hear it. They're often afraid to ask questions. Multiple chronic illnesses. Medications may help one thing and then it causes side effects of another. You have prescribing cascade, which is the prescription. They prescribe more meds to combat the adverse effects of the medications that were used to treat the illness. So they give a medication to treat the illness, and that causes GI upset. So then they put them on a GI medication. Well, then that medication causes constipation. So then they have to be on another medication to combat that constipation, and so on and so forth. So in general, for 65 years and older, we're going to start low and go slow because we understand that they're not going to metabolize these medications as quickly. They're not going to be excreting them as readily as they should. And then there's the Beers criteria. This is used to identify drugs that may be ineffective or cause adverse drug reactions in older patients. It's a list. So it's always good to look at that to see if they fit in the Beers criteria. So pharmacokinetics. Well, older adults, they have decreased cardiac output from atherosclerosis, which causes decreased perfusion to your liver and your kidneys. If you have decreased perfusion to your liver and your kidneys, you're going to have decreased function and poor circulation, okay? So absorption is decreased from decreased circulation, right? Decreased blood flow, decreased acid production, decreased GI motility. They often have constipation. Distribution is increased. Decreased liver function means that you have decreased protein production and decreased protein binding. So if you have decreased protein binding, you have more free drug to do stuff in the blood. You also, with decreased liver function, have decreased metabolism of the drug, so there's more drug hanging out in the bloodstream because it's not being readily metabolized. Metabolism is decreased. We just talked about that. Decreased production of cytochrome P450. They have decreased liver function. We have excretion is delayed. They hold on to drugs longer because they have decreased renal function. a decreased glomerular filtration rate, which is a decreased renal perfusion. So your glomerular filtration rate, if you imagine that this is your kidneys. Imagine your kidneys is like a giant colander. It's a bowl with holes in it. And where each of those bowls is, where each of the holes are, is like a straw. So those holes, the straw is where is your renal tubule. Okay. And your glomeruli they bring in the blood to be filtered through the holes, okay? And it goes through the renal tubule, and at the renal tubule is where it's decided that it's either going to go back into the blood or it's going to go out as urine. Now your glomerular filtration rate has to do with how quickly fluid is filtered through here, okay? So say if you have this colander and you pour a pitcher of fluid through it, if all those holes are open, then the fluid is going to go right through it really quickly, right? That's a high glomerular filtration rate, high rate of fluid going through per minute, okay? But if, say, your holes get clogged up, this can be caused from high blood pressure, a lot of glucose in your system, so hyperglycemia, other things like that. It can close off these holes. So imagine if you have this colander still with holes in it, and some of the holes are starting to be closed. Well, if you pour that same amount of fluid, same pitcher of fluid into this colander, well, it's going to take a little bit longer to go through the holes, right? Because some of the holes are clogged up, okay? So that's your glomerular filtration rate. So glomerular So the glomerular filtration rate really tells you how many holes are open. What percentage of your holes in your kidneys are open. Okay, so as you get older, you have a decrease in your glomerular filtration rate. So that means more and more holes are closed, okay? So your blood cannot be filtered as effectively as it was before, as more and more holes are clogged up, okay? So cultural considerations, the influence of ethnicity and genetics on drug response can be environmental factors like their diet, nutrition status, other cultural factors, genetic, inherited factors like the enzymes that are present. We need to consult with the patient before assuming beliefs, so just ask them about their beliefs. Barriers to adequate health care for the culturally diverse, language, poverty, access, pride, beliefs regarding medical practices. We need culture assessment. Is there a need for an interpreter? It must be a certified interpreter, and it must be their native language. Health beliefs and practices, whether past uses of medication, over-the-counter herbal treatments, folk remedies, and home remedies. Religious practices and beliefs, their dietary habits. They may interact with some, drugs that they're getting. Usual response to illnesses, and then responsiveness to medication treatment. So some drugs elicit different responses in different cultures, and patterns of communication may differ. So it's always best just to ask questions. So ethical considerations, the nurse has a responsibility to provide safe nursing care. They can provide information and assist the patient in making decisions, but we cannot make the decision for them, okay? The nurse has the right to refuse. In fact, often they say, oh, well, what would you do? You can't answer that question, okay? All you can do is, give them the information. The nurse does have the right to refuse to participate in providing treatment that is against their personal ethics. However, it must be done without deserting the patient. Over-the-counter drugs, their labels must have the purpose, the use, and specific warnings. FDA black box warnings, these state that there's a potential for serious hazard. It indicates that there's evidence of an association of a serious hazard with the drug, and it's required. If the FDA notices that there's a trend with a certain medication, they will require that there's a black box warning placed on the prescription. Side effects or over-the-counter medication. Ibuprofen has a black box warning. So side effects has to have the dosage instructions, has to list the active and inactive ingredients, and how to store the medication. Patient education. It's really important that we teach our patients how to read the labels. They need to understand what the active ingredients are. They need to understand that it may relieve their symptoms without helping the cause. So over-the-counter drugs can create a problem because the condition could get worse. For example, if you take Pyridium, which is it's like a anesthetic for your GU tract. So when you have a urinary tract infection, it stings and burns really bad to pee. So you can take Pyridium and it will stop that burning and stinging, but it doesn't do anything to help your UTI. And if you don't treat a UTI, then it can cause kidney damage, and you don't want that to happen. So sometimes over-the-counter drugs can cause some problems if it can mask bigger issues. Make sure they're taking appropriate products, the correct dosing, and make sure they know about common adverse effects and drug interactions. We're talking about herbal and dietary supplements. Now, you don't have to memorize the dates on here. It's just to kind of give you an idea of how this has evolved. About 50% of U.S. adults use supplements. Only about 70% of them don't tell their provider. Most of them are either embarrassed or they think it just doesn't matter, but it is extremely important. There are about 1,000 new products out on the market every year. They're intended to augment the diet, which means something that they're just not getting in their diet, which is important, like vegetarians or those that may need supplemental things. So it started in the 1960s. There was concern over effects of medications. So patients didn't want to take so many medications. They were like, I don't want to take a med. They started moving toward herbal things. And so in 1974, the World Health Organization encouraged the use of traditional medications. They said, no, you guys really need to do the medications that we've, said are effective and said are safe. But the patients continued to use supplements anyway. So in 92, the Office of Alternative Medicine, later renamed National Center for Complementary and Alternative Medicine, was created to study complementary medications because people were doing it regardless of what the World Health Organization was saying. So in 94, the Dietary Supplement Health and Education Act was enacted. It ensured the safety but not the efficacy. So it ensured that there was clean production, there wasn't any rat pellets or whatever in the lab, but it also prohibited unsubstantiated claims. So it couldn't say that it cured a certain illness. In 2002, the USP started certifying products. This was completely voluntary. It still is completely voluntary, and all it does is it verifies the content. So if I'm taking glucosamine, 1,000 milligrams or whatever, then all it says is that, yes, there is 1,000 milligrams of glucosamine in this bottle, and that's all it does. So in 2007, FDA states manufacturers must provide data that demonstrate that the product identity, so it must say what it is, must say the composition, quality and purity, that it's free from contaminants, the strength of the active ingredients, and it can claim an effect but cannot promise a specific cure product on the product label. Okay, so it'll say always that it doesn't treat a diagnosis, it doesn't treat an illness, but it has to say that it can't do that. Supplements do not need approval from the FDA before they are marketed. So just FYI. Patient education, so assessment. We need to gather subjective and objective data. So what are their allergies, chronic medical conditions, their current condition, any liver renal function, and how is their circulation. We need to be aware of verbal and nonverbal communication, their readiness and motivation for learning. Are they even interested in what we're saying? Okay. Level of anxiety. Increased anxiety means a decreased ability to learn. Okay. So if they're super anxious, then you might as well wait because they're not hearing a thing you're saying. Unmet physical needs. If they're in a lot of pain or they're super nauseous, they're thinking about that and they're not listening to you. Okay. So we need to meet their physical needs first, and then we can start with the teaching. The patient's level of understanding. What is their level of knowledge? What do they already know? Okay. Health literacy and beliefs. So what do they think about healthcare? Is it a good thing? Is it not a good thing? Do you go there to die? Etc. My mom thinks every time she goes to the ER that they're just going to keep her in the hospital until she dies. So some people have interesting health beliefs, and so we need to address those. Their native language. Use an interpreter. Do not use the family. You can't use a family. You can't use their friends. You have to use an actual certified interpreter for the hospital. We need to know about their environment, their home and work environment, their family relationships, the current treatment that they're doing, okay? Their financial status. Are they able to afford what was prescribed for them? If not, then we need to try some cheaper options, okay? Because they're not going to take it, and then they're going to be back in the hospital. Their self-care abilities. Are they able to take care of themselves? Do they have any limitations that hinder their ability to take the medications? Okay. Their nutrition, because some medications require certain things. Race and ethnicity, different thoughts related to medical treatments. So we need to find out what their thoughts are. And then the Beers criteria, the meds associated with risk in older adults. Patient education, nursing diagnosis. These are certain diagnoses that you guys can use on your care plans. So deficient knowledge, what does that mean? It means they don't know why they're on the medication. Okay. Risk for falls. This would be due to an adverse effect. If they're on a medication to lower their blood pressure or that causes sedation, this is a potential nursing diagnosis. Ineffective self-health maintenance. This means they're not taking their medication as prescribed. Okay. Readiness for enhanced self-health management. That's a lot. This means that they want to take better care of themselves. Like they want to learn how to do it better. Okay. Impaired memory. They keep forgetting. Risk for injury. Could be potential for toxicity. It could be because they are they have decreased renal function or liver function. Non-compliance. Non-compliance means they know what they should be doing, but they don't want to do it. Okay? Goals and outcomes. They should be specific, measurable, attainable, realistic, and timed. This is straight from your care plan instructions. Implementation. You should convey clear, simple, concise information. It should be oral and written so they have something to refer to later. Consider their age and developmental level, especially if they're kids. Native language should be a credentialed interpreter. You should offer return demonstrations so that you can see that they do know what you're talking about. Effective teaching begins upon admission. You want to individualize the teaching, okay? Provide positive feedback and rewards for when they get things correct. Create medication calendar so that it's more organized. Use visual aids. You guys like visual aids. They like visual aids. They learn better with that. Involve the family members because this will help the patient remember later on. Written materials should be at a 6th grade reading level. 20% of the population reads below 5th grade. So even having it 6th grade reading level, you're still going to miss 20% of the population. Try and use pictures and diagrams and or illustrations for those visual learners. And then documentation. You want to do a learner assessment, which means what are their learning needs and how do they learn the best? Okay? What are the outcomes? What are our learning goals? What do you want them to learn? And then what content did you provide? What strategies did you use? What was the patient's response to teaching? Were they able to teach it back? Did they do a return demo, etc.? And then overall evaluation of the learning. Did they meet their goals? Did they learn what you wanted them to learn? And ask specific questions. When do you take the medication? Why do you take it? When should you call your provider? Stuff like that, so that you can really evaluate whether or not they get the information. Have the patient repeat the information. Have the patient give return demonstration. And then was our plan effective? The changes that needed to the plan, and then create that new plan. Okay.